And the next speaker will be Saurabh Jain for the keynote address on botulinum toxin in childhood strabismus. Please.
Thank you very much, John. Thank you to the Scientific Committee for inviting me. It's a real pleasure to be back in the City of Joy. It's been so gratifying to see such a large room allocated for pediatric session. That always makes me happy. And it's really great to see the other talks, and especially the muscle transplantation, really fantastic. I'm going to talk to you about something a little bit different. And I don't know if you already do this, but I found botulinum toxin to be quite useful in childhood strabismus. So I'm just going to present to you some cases, and the good news is I can stop whenever my time is up because they're just cases. So, right. So, botulinum toxin is something that's been around not that long actually. It was only licensed in 1989 by the FDA. So, we use it, as you know, in adult strabismus quite a lot. I won't bore you with the pharmacology, but just to say what it does, it blocks the release of acetylcholine at the pre-transmitter level. That's what toxin does. Okay, it comes in various forms. So in the UK, you can have Botox, which is about 250 pounds a vial. You can have Dysport, which is cheaper, and you can have Xeomin, which is cheaper still. And our trust very much would like us to use Xeomin, but I use Botox. You reconstitute with saline. One thing I tell the residents always, never shake the bottle, because if you shake the bottle, you denature the protein. So try not to shake the bottle. Remember this graph because it will come back to haunt us a little bit later. And this is the pharmacokinetics. So when you inject toxin, nothing happens on that day or the next day. It only starts working in 2 or 3 days. It peaks in 2 or 3 weeks, and it slowly goes away in 3 or 4 months, okay? So this is our first case. It's an 8-month-old boy which has a big esotropia noticed soon after birth. No other concerns, okay? Fixes and follows very well with each eye, no limitation, large infraoblique overactions, big esotropia. So for the more junior members of the audience, this of course is an essential infantile esotropia, which has these features. It's always in infancy, as the name suggests. It's a moderate to large angle. They cross-fixate. They have manifested in nystagmus, DVD, infraoblique overaction, etc. This is a very typical. Now, although this case is typical, we still don't know why it happens, and there are two competing theories. So the Claude-Worth theory says, actually, your arch is not complete. We don't have the keystone. You don't have the ability to fuse. So it doesn't matter where your eyes are. You just cannot fuse, okay? The Shew's theory says, well, actually, we think the problem is motor alignment. If you could take the motor alignment back to where it should be, maybe you'll start fusing. And they are very opposing. In the UK, we very much tend to side with Claude-Worth. So we tend not to go in for early surgery for these patients on the whole, okay? But what are the treatment options? Well, there are many, and whenever there's many options to treat something, it means there's no one good option. So you could just watch them, okay, correct the refractive error, which they don't usually have, or you could operate early, so you could either do a bimedial recession or a recess resect. Now, the studies have shown that the results of bimedial and recess resect are the same. I personally prefer bimedial because it's a symmetrical procedure to both eyes. You're just recessing a muscle, so you're not losing any tissue, and if it all goes wrong, you can always re-advance it, right? We prefer to do a hangback because, again, I have a lot of residents, and it's much better suturing anteriorly where you can see what you're doing, but I think to fix the sclera is actually a very good technique, and you get less inflammation because you leave less vicryl behind. And toxin is just another addition to our armamentarium for this condition. So study after study has shown that early surgery does improve stereoacuity outcomes. The early surgery is defined by people that essentially comes down to less than 18 months, probably less than 12 months. Okay, and that's what most people would understand by early surgery. And to be honest, at least in the UK system, we don't get to see them before this time. So why the hesitation? Why are we still talking about if early surgery is such a good thing to do? It's because the ocular alignment instability is common. Up to 50% of them, you don't actually know where they're going to end up. We also know that the rate of resurgery can be quite high, up to 50% in the next 5 years, up to 2/3 of them in 10 years if you include the oblique. So I think that's something to just counsel the family about. So in the ELIS study by Herb Simmons, he showed that the children operated early had better gross stereopsis at the age 6, but they did need more operation. That's really the takeaway message from this slide. If you do early surgery, you have a higher chance of them needing a second procedure. Okay? So in this scenario, I think Toxin is a good halfway house. Okay? And I do it under general anesthetic. I use the same kit that I use for the adults, the same EMG machine. Ideally, you want them lightly anesthetized, but ideally you also want them sitting up or slightly sitting up because you don't want to affect the lid to cause ptosis. And one of the key things I've found, if you leave the needle in for about 90 seconds, 90 seconds by the clock, you reduce the incidence of postoperative ptosis because there's less leakage. This is the Mendonca forceps you can use because it actually grasps the tissue, and you can use that to inject it instead. We don't have one in our center, but I've heard all about it from the forum, so I don't know if any of you have any experience with that. Okay, this is our child, this is post-toxin, and this is what you want to see at 2 weeks. You really want to see an exotropia because you want to sort of reset the dynamic oculomotor system to see if you can get the deviation better. This is another child of mine who just needed toxin, actually needed no other surgery. So which children does this work for? Who are the best children to perform this procedure on? If you look at the literature, this is the largest study by Alejandra Campomanes and Jill Bennebaum, and they looked at almost 450 patients, of which 322 received toxin. 50% of them, just one injection. 50% had 2 or 3 injections, and they used 5 units for less than 50 diopters, 7.5 for more than. And this is their cohort. Now, the interesting thing in this cohort is the toxin injection group was significantly younger. They presented earlier, which is why I think there was a hesitation towards surgery because of the ocular deviation and stability we talked about, and that's maybe why they had the toxins. There's a bit of a bias built in the groups, but as you know, controlling in strabismus is almost impossible. RCTs in strabismus are so difficult for that reason because, as you know, every person is different. And this really is the key statistic. Okay, they found if your deviation is more than 30 diopter, you're probably better off having an operation. If your deviation is 30 diopters or less, toxin was the same as surgery. And that's interesting, and that might be something you might help to guide use. It's not to say you should not use toxin in children with a bigger angle. We have used toxin in children with big angles to reduce the angle to something that will need only 2 muscles rather than 3 muscles. So there is a role there as well. This is a really good meta-analysis of all the studies on toxin in infantile esotropia. And essentially what it says is the group success rate, success being here 10 diopters or less, is about 76%. Mean number of injections is 1.4. It was interesting. Higher the dose injected, lower the success rate. And I think this is because the higher the dose injected was in the children with higher deviation, which is why the success rate was less. Also interestingly, EMG guided injection the same as open sky. So I don't think there's any point in opening up the conjunctiva because you might have then just do the operation. So the whole point is to be non-invasive. So EMG is the same as open sky. They're significantly better without using EMG. They had a bit of ptosis, but a lot of that got better. Okay, and one of the things they noticed was tonic pupil, which can happen from time to time. So this is my second case. Okay, there's an 8-month-old boy, again a large angle esotropia, but what's different here? He has developmental delay secondary to periventricular leukomalacia, and the parents are very keen on treatment. Now you have to be a bit careful in these patients because a lot of children with developmental delay can go on to develop consecutive exotropia. So we always a bit hesitant to offer surgery in this age group, and a lot of them require more than one procedure. However, you do not underestimate the psychosocial impact of a child with developmental delay and a large esotropia, and the parents were keen that he look as normal as possible in their words. So what we did for him, we just offered him toxin, and he had 1 toxin injection. This is him just 3 weeks later. You can see the ptosis, he's lifting a chin up. But that's a good sign. He's trying to use both eyes, and this is him 2 years later. So he had a really good alignment, and I felt that I wasn't scarring his medial recti without giving him the chance of the consecutive exotropia. So we actually collected all our cases and published them a few years ago. Okay, this is my third case. This is a 14-year-old girl who, and we already heard a fantastic talk about this. She had an acute onset of esotropia with double vision, and this is what she looked like, right? She didn't show the esotropia very well at all, but she had a sudden onset ET, about 30 diopter, lost her stereopsis, and the family was very very concerned. We did neuroimaging, of course, which didn't show anything at all. We already heard about actually the 6 types, but these are the 3 most common A and AET types, the Swan type, the Franceschi type, and the Bilchowski type. And in this girl, we felt we do need to do something. She's probably the second, the Franceschi type, because of low hypermetropia. And again, you can operate or you could do toxin. So in this case, we elected to do a toxin, 2.5 minutes into each muscle on the EMG. Now, it's really important. You warn the family they're going to have an exotropia, because there's a lot of phone calls and tears that happen when suddenly the child's gone from in to out. But she did really well, and she regained her stereopsis. This is the next case. This is the one we also published in JAPOS. This was a 3-year-old boy, and mom kept noticing intermittent turn of the left eye. Now, camera phones have been the biggest boon, I think, in pediatric ophthalmology, because people will always have pictures of their children. Okay, so that for us has been, and she would say, sometimes it's there, sometimes it's not there, and she's right. Some days it's there, some days it's not there, and we got her to actually do a diary. She did a diary, she did good day, bad day, good day, bad day, and you see, it's a 24 to 48 hour cycle, so it's a good day, bad day, good day, bad day. So this is, of course, on the good day, when he comes, he's straight. He's got stereo, no problem. On a bad day, he's got a big onset ET with no stereo at all, okay? So in this child, we offer them 2.5 units to each medial rectus. He had got a big consecutive XT, which I like. I'm quite happy to see that consecutive XT, because I feel I've got the toxin where I wanted. 8 weeks later, intermittent XT, 6 months later, all gone, and he's not had a recurrence since then. So it can work in cyclical esotropia. And again, why choose toxin over surgery? Just because there was a bit of hesitancy, because the angle was changing, the family was not keen on having an operation, which I absolutely understand. So this is another rare form of strabismus, which is 48 to 24 hours cycle. In some of them, the manifest phase will increase over time, and they go on to a constant squint, and then fair enough. I think then surgery and toxin have an equal role. It's just in this case, we felt if we could break the cycle, we might keep him straight, which we managed to do, and he's done very well. This is another child. Now, either she just has one frock, or they send me pictures on the same day, but she does have to have a straight day, and then suddenly she says, I see 2. Okay? So she had the cycle. She actually had surgery because I felt she was getting more and more manifest over time. There's another patient who flew all the way from Hong Kong to London to have a toxin injection. I felt like a bit of a fraud, but this is, so it's very difficult actually to see because of the epicanthic fold, but she's straight, and then in, and that she has a slightly shorter cycle. So cyclical esotropia is difficult to manage. You can observe them, you can use toxin, or you can use surgery. And surgery, bimedial recession is the same as recession resection. If you're going to operate for the full manifest angle, and that's the key message here. Okay, this is my last case. This is I still have PTSD. So this is an 8-year-old girl. It started off really nicely. 8-year-old girl, intermittent XT. I said, I know what to do here. She's decompensating. I'll do an operation. She'll be fine. Everybody will be happy. She's got good stereo. We did the operation. So I did a recess resect, 7.5, 6.5. Done with my fellow, no problem at all, uncomplicated surgery. 6 days after the surgery, extremely unhappy. No more double vision, but the face is turned to the right. And why? Because she has a massive limitation of abduction and a massive consecutive esotropia. So, and no stereopsis. So, a lot of reassurance. This will relax out. Don't worry, it'll be okay. It's 4 weeks now. Now, the granddad is coming to the appointment as well. Lots of tears. As the mouth-orthopedist says, she's very frustrated at the moment and very concerned about her child's well-being because of this. And now the ET has gone. It's gone from 40 to about 16, 25, but there's still this big limitation. So what do you do? Okay, has the lateral rectus slipped? Should you pull it up? Can you do something else? So because there was a lot of familial concern, and now we have 4 weeks and nothing's happening, we did some toxin. So under anesthesia, I looked at the lateral rectus. It looked like it was in the right place. So I did some toxin. 1 week post-op, great. Everybody is happy. 4 basin, stereopsis is back, great. But you remember that graph I showed you, right? 2 weeks. This is what happens in 2 weeks. And now she's got an exotropia. So now the family is like, why can't you get it right? Now we're going the other way, not turning the head the other way. And you can see here that big impact of the toxin to the right medial rectus. And all you have to say is reassurance, it's okay, this is what's supposed to happen, it will be fine. and it was. 6 months post-injection, it's child's happy, mother's happy, we're back to 85 seconds of an arc, and the exophoria is well controlled, and she's now firmly discharged, although I see her at the station from time to time, they wave at me. So just to recap, I think Toxin, think of it as an armamentarium to treating small angle infantile esotropia in children developmental delay, consecutive exotropia or esotropia, acquired esotropia, and you can use it in adjunct to surgery for 6th nerve palsy or rarely in exotropia. Thank you very much.